Blunt force impacts the skull, forcing the brain to contort and bounce against rigid cranial walls, tearing blood vessels and shearing complex neural pathways. These traumas are frequently the result of sudden decelerations, most commonly severe vehicle collisions, where the body stops but the brain keeps moving. In the immediate aftermath, emergency medicine takes over. The priorities are strictly physiological, stabilizing vital signs, using CT scans to locate hemorrhages, and surgically relieving intracranial pressure to keep the patient alive. Once the physical trauma is contained, the patient transitions from the surgical bay into intensive care. The fight for immediate physical survival is won, but an entirely different crisis begins here. Clinical data shows that up to 100% of patients who survive a coma related to brain injury will exhibit severe cognitive impairment once they are medically stabilized. The surgical tools that save the body, the scalpels and monitors, are ineffective at repairing the mind. There is no physical instrument that can reach in and reconnect shattered neural networks. Instead, the damage manifests in behavior. Patients wake up displaying chaotic, wildly unpredictable actions. To an observer, these reactions seem random, making the exact degree of cognitive damage exceptionally difficult to measure. To solve this, multidisciplinary medical teams rely on the Rancho Amigos Revised Scale, or RLAS-R. It is a clinical assessment tool designed to translate these highly subjective behavioral observations into standardized, trackable data points. Without a standardized taxonomy, clinical interventions are difficult to calibrate, as the medical team lacks a precise method for matching treatment to a patient's hidden cognitive state. This chart maps the cognitive continuum of a recovering brain. The y-axis measures the clinical assistance required, and the x-axis tracks the cognitive response. The baseline is level 1. The patient requires total assistance. As the brain begins to fire, the patient moves to level 2, displaying a generalized, inconsistent response. At level 3, the response becomes localized. This cluster makes up the emergence phase, and it demands a highly specific set of environmental controls from the multidisciplinary team. The clinical protocol begins with a mandatory assumption. Regardless of how unresponsive the patient appears, the staff must operate as though the patient can hear and comprehend every word spoken in the room. Treatment takes the form of severe sensory restriction. The lights are kept dimmed to lower visual input. The room is strictly limited to 2 visitors at a time. Even familiar stimuli, like a patient's favorite music, are restricted to 5 or 10-minute windows. This is because early-stage neural networks are fragile. Bombarding them with normal, everyday levels of sensory input overwhelms the system, triggering exhaustion and cognitive regression. In this phase, the patient's brain cannot process or filter the outside world. The highly controlled hospital environment must act as that missing filter for them. Returning to the scale, the curve enters a volatile middle phase. The absolute need for physical assistance begins to drop, but the cognitive response pattern becomes highly chaotic. This chaos peaks at level 4. The patient is confused and agitated, requiring maximum assistance from the medical team to prevent injury. There is a clinical paradox at work here. The patient may exhibit bizarre, aggressive, or hyperactive behavior, but this volatility rarely stems from their surroundings. The aggression originates entirely from their own severe internal confusion. As the swelling subsides and neural pathways solidify, the patient progresses to levels V and 6. Behavior shifts from inappropriate to appropriate, and their reliance drops. A severe memory constraint defines this stage. A patient can execute highly familiar pre-injury routines, like washing their face or brushing their teeth, but they are unable to form memories to learn new tasks. To manage these specific deficits, the medical team enforces rigorous daily structures and precise de-escalation protocols. Clinicians are trained never to react to sudden emotional or physical outbursts. Instead, they remain with the patient, providing a calm, steady presence until the internal confusion passes and the patient regains control. To bridge the gap in short-term memory, the team relies on physical anchors. They use photo books, daily journals, and physically model every new action in real time before asking the patient to attempt it. During the agitation and confusion phase, the clinical staff effectively serves as the patient's proxy frontal lobe. They provide the external executive function that the injured brain temporarily lacks. The final stages map a steady trajectory toward cognitive independence. Assistance drops to standby levels, while actions become purposeful. At level 7, patients are automatic and appropriate. They navigate daily schedules with near-zero confusion, but lack insight into safety risks. Progression through levels 8, 9, and 10 marks the return of true executive function. The patient recovers the ability to multitask in distracting environments. They begin to independently anticipate physical or cognitive obstacles and can invent their own tools and strategies to compensate for lingering deficits. But the return of high-level processing brings a psychological toll. Patients in these final levels frequently struggle with bouts of depression, irritability, and a remarkably low threshold for frustration. This occurs because the brain has healed enough to achieve full self-awareness. For the first time, the patient can clearly recognize the gap between their pre-injury capabilities and their current reality. Here, the clinical strategy pivots. Medical staff deliberately pull back, removing direct supervision to force the patient to rely on their own problem-solving skills. Rehabilitation exercises are designed to mimic real-world environments, introducing deliberate distractions and complex scenarios that test the patient's ability to maintain safety on their own. True functional recovery is not measured solely by physical strength. It requires the cognitive resilience to navigate an unpredictable environment safely, even when permanent impairments remain. Looking at the completed model, we see a clear inverse relationship. As internal cognitive function rises, the need for external clinical scaffolding falls. This rigorous psychometric tool boasts an inter-rater reliability of 0.94, meaning practitioners consistently assign the same level to the same behaviors. However, a clinical model is just an approximation. The brain is biological tissue, not software, and real-world recovery rarely follows a perfectly smooth curve. Neuroplasticity, the biological process of neurons reaching out to rebuild severed pathways, is a remarkably delicate, highly sensitive process. Because of this fragility, patients will frequently regress to lower levels, skip phases entirely, or exhibit overlapping symptoms from multiple categories on the same day. These fluctuations are often driven by basic physiological variables. Things like poor sleep, subtle nutritional deficits, or an underlying physical illness will immediately disrupt a patient's cognitive output. The multidisciplinary team uses the Rancho Scale in real time to track these daily, sometimes hourly shifts. It allows them to instantly adjust their therapeutic approach to match the exact capacity of the patient at that specific moment. This granular tracking offers prognostic guidance, helping clinicians estimate long-term vocational outcomes and the likelihood of successful community reintegration. The Rancho Scale acts as a dynamic translation tool, syncing the external clinical environment with the specific needs of a healing mind.